A stone size, that's one beneath other factors we are recognizing when we want to decide upon a particular stone therapy, stone removal intervention. And the stone volume, from my point of view, doesn't add any additional, doesn't lead us elsewhere. And I want to show you why I think about that. Usually a stone is not a correct three-dimensional structure like a ball or a cylinder. It's a complex, irregular, three-dimensional structure and can have very complex geometry and in particular a complex surface. There's a study from UK. They evaluated retrospectively 100 stone patients on the CT and tried to measure the stone volume in different methods. They could show the bigger, I don't know if that works, yeah, no, there's no space. The bigger a stone is, the bigger the diameter is, the less accurate is the volume measurement. The reason for that is that the average shape of a Reynolds stone changes with the diameter it has. A similar study from Germany, but they also recognized the stone composition and incorporated in their evaluation. And they could show that it's not the acquisition technique that makes a difference in the measurements of the stones. So it's not the pre-processing or processing of the CT itself, not the radiation or the denoising levels, but it's the post-processing, let's say, the imaging algorithm, the kernel used. And that makes a difference. And the second point is that stone composition makes a difference in volume measurement. They could show that there's a difference up to 40% in a particular measurement. And we are facing three-dimensional structure, so 40% means a lot. 40% in a stone like this means in one axis a 40% increase of stone volume. But if there are all three axes going up for 40%, that means a volume evaluation, a volume enhancement in 2.7-fold. So a 2.7-fold increase in stone volume. So the determination of volume is pretty much prone to possible errors. We must face that. When is it of interest? In particular, stone size or stone masses of interest in those stones where we have the choice between different treatment modalities to remove the particular stone, so practically in the mid-size and the smaller stones. And it's not only the guidelines, like here, the guidelines of the EIU, who might help us deciding, but there are scores and nomograms and reviews to help us decide. And usually, scores are developed by re-evaluating a mass of cases. So scores are reliable in how they weight particular factors. And I want to show you how they weight the stone size. And if we look back to Thomas Case and her group in London, the guys score, they just, the factor of stone size was subordinated. It was just be present or partial or complete stack one. So a very, very rough influence on the score for percutaneous lithotripsy in this score. And the STONE score is another score evaluating the outcomes for percutaneous lithotripsy. That's from the Arthur Smith Institute in New York in 2013, I think. And they already, they at that time gave the stone size in 2 dimensions, so in square millimeters, but then they stratified them by 400 to 400 square millimeter steps. So they just gave 4 steps for weighting the stone size. Another thing is the shockwave lithotripsy. For shockwave lithotripsy, stone mass is an independent risk factor, and that's why I chose this slide. Although it gives the volume calculated with the ellipsoid formula as one of the parameters predicting success, next to skin to stone distance and Hounsfield units. For retrograde intrarenal surgery, however, there's a score I found just published 2 years ago from a Japanese group. It's called the Toho score because of the hospital there, but also because of the factors they use. And there they use tallness, so size in one dimension, not 2 dimension, not 3 dimension, in 1 dimension, and there in 7 millimeter steps up to 5 groups of size. So what we can see is that the size is just a rough factor in all these scores, but there are even other factors that should influence the decision, the preoperative planning in these patients. Sure there are. There's the stone composition, if we might guess it or might know it from previous stone sessions, and there's an in vitro study showing that calcium oxalate monohydride for shock of lithotripsy needs much more energy to fall apart into even bigger fragments. And as well with thulium laser, it's the work from Oliver Traxer, he already mentioned himself now in his presentation before, showing that calcium oxalate particles created by thulium laser are somehow bigger compared with other minerals, but still small enough, not perhaps to 250 micron, but to 500, below 500 micron. So for me also the stone heterogeneity is another factor being important. The heterogeneity is nothing else than the standard deviation of the stone density within the stone, and that for me is a figure that explains why heterogeneous stones, even if they have an overall density of 1,500 Hounsfield units, might break well, or others might not break well with shockwave lithotripsy. So besides the stone itself, what else matters? If we look at a treatment of stones, and I want to challenge this Italian very well done prospective randomized trial. Why this work? Because it shows the same results for stones from 5 to 20 millimeters in size. So independent from the size, they could show that the time to treatment influenced the outcomes much more, obviously, than the stone size. The early treatment within 12 hours, that's the blue line, showed impressively better results after 1 day, after 1 week, after 1 month, and after 3 months for both stone-free rate and efficiency quotient. And once again, independent or correct for stones between 5 and 20 millimeter in 1 diameter. And besides that, there are other factors we all know that's based on the patient itself, on the condition, on the comorbidity, and the available resources and expertise we have, in particular in the COVID pandemic time. So saying all this, I want to invite you just have a look at these 3 cases I want to present you very briefly, and consider by yourself if you would change your treatment modality based on the stone volume if you knew it. A complete stack-on on both sides, that's a non-enhanced QB, or this 1 centimeter inferior calycial stone, the Hounsfield units are given there, and in the middle picture you can see the calycial neck and calculate it, see it, or there's 1 centimeter pelvis kidney stone, again Hounsfield units are given. From my point of view, in none of these cases I would change my treatment modality based on the volume of the stone. So in conclusion, for clinical use, not for research use, But for clinical use, the determination of volume, because it is prone to error, in particular for bigger stones, does not help that much. If it's done, it needs to be specified how the calculation was done. For clinical use, the one-dimensional or two-dimensional appearance is sufficient to judge upon the treatment and do the preoperative planning. Only for shockwave lithotripsy, the stone mass might be an independent risk factor, although this, for me, doesn't seem to be a decision criterion. And remember that other factors might be much more important for the treatment decision. Thank you.
I think the question is really, should we try to evaluate the stone volume, even we are not perfect, or should we still keep in 2022 the largest diameter to give recommendations? There's no discussion, you know this table. Very strange that in 2022 we still respect this limit of 1 centimeter for ureteral stone and 2 centimeters for a kidney stone to make the treatment. Something interesting, most of the stone that we are treating, all of us today, they are in between 1 to 2 centimeters. And very interesting to see the guidelines that in between 1 to 2 centimeters, you can do whatever you want. You can select shockwave, you can do flexi or PCNL. That's great in terms of guidelines. But remember that if it's a real 1 centimeter stone or 2 centimeter stone, so a complete spheroidal stone, it means that we are moving from 500 cubic millimeter to 4,000. So between 1 to 2 centimeters, the difference is 8 times bigger in terms of stones. How can we imagine today that we do exactly the same job when we are treating stone 8 times superior in terms of volume? Another question is, why do we still keep this 2 centimeter limit in terms of largest diameter to fix the guidelines? And we need to recognize that this 2 centimeters limit is coming from this debate. And most of us, we participate to this debate, shockwave versus PCNL. And in the past, we realized that if the stone was more than 2 centimeters, so supposed to be more than 4,000 cubic millimeter, PCNL was much more superior to shockwave in terms of complications, in terms of stone free rate. And that's the explanation for this 2 centimeters limit. Do we really evaluate actually the place of flexible ureteroscopy, retrograde intrarenal surgery in this debate? Not really. Of course, when you have to treat this very complex stone, to be honest, it's not every day, even for the most expert people in this room. I would say that what do we need to consider? Can we just consider the staghorn stone definition to make the decision, or are we not concerned by the total stone volume of these very complex ones? So, to me, I think it's really the time to redefine these limits, not using the largest diameter, but really to produce actually guidelines using the total volume. Why do we need this? We need just this evaluation regarding the stone volume just to produce more precise guidelines, to give the best recommendation in terms of stone treatment, but also for personal evaluation. Because if you compare, if you know exactly the stone volume that you are treating with one technique or another one, this is the best way actually to improve in terms of your technique. It's also the best way to evaluate our residents, our fellow, if they improve actually using the technique. And I will give you some example. So I fully agree with Christian that the most important parameter actually to make the decision is the stone volume, so the size of the stone, and the stone composition, something that we already evaluate with the pre-op CT scan. We need also to admit that most of the people, most of the patients, actually, when we treat patients, we ask for a pre-op, a CT scan with low dose protocol or even now ultra low dose protocol. We recently published the use of this free software that you can find on the internet just to use by all urologists to calculate the stone volume. Let's come back on this formula. You know the formula regarding a sphere. It's 4 divided by 3 multiplied by p by the radius cubic. Let's try to make this formula a little bit more simple. Because again, I'm not sure that today we need a perfect evaluation of the stone volume regarding each cubic millimeter, but at least to do something better than the largest diameter. This formula is very simple to be simplified. If you consider that P is 3.14, you can simplify by 3. So it means that the formula is in fact 4 by cubic radius. The radius, that's the diameter divided by 2. So you can replace this formula and you can again make this formula much more simple. You divide by 4. So the formula is in fact the 3 diameter, or the diameter by 3, and you divide by 2. And then you obtain the volume, an approximate volume. I agree with you, maybe not perfect, but much more superior than just the largest diameter. And remember that this formula is the one we are using actually to calculate the volume of the prostate. And we accept it and we use it to treat a patient with a BPH. 2 centimeters, what does it mean in terms of largest diameter? I just give you an example. This is 2 stones, 2 different shapes, 2 centimeters, both of them. If we look at the second diameter and the third one, if we calculate the volume, the one on the left is 4,000 cubic millimeter. It's a real 2 centimeter stone. But if you compare to the second one, it's just 1 cubic centimeter. So it's 4 times less. Same largest diameter, but the total volume is totally different. If we compare these stones, actually, and if we simulate 1 cubic centimeter versus 4 cubic centimeter, in terms of volume, what does it mean? 1 cubic centimeter is an equivalent of 1 stone, a single stone, round 1.25. 4 cubic centimeter is 4 times the same. Are you sure that you will treat exactly those 2 patients with exactly the same technique regarding the stone volume or regarding the 2 centimeter largest diameter? You can keep in mind these numbers, very easy to remember. When you are moving from 10 to 12, if it's real stones, you multiply the volume by 2. If you have an additional 3 millimeter for the diameter, you double again the volume. And when you move to 18, you get an additional 1,000 cubic millimeter. And when you go to 2 centimeters, now it's 4,000. So again, from 10 to 20, if it's a real stone, you move from 1 to 8 times for the same volume. Why is it important to calculate the volume? Because today we know more or less in terms of energy when we are using laser, how much energy we need to fragment, to complete the fragmentation of stones. In the lab, it's already calculated. We know exactly how many joules we need to dust 1 cubic millimeter of stone, different stones. It's already published. It's also published that if you go in the real life, you should proceed to these numbers. And you can calculate. If you know the volume, you know the total energy that you produce, you know the time, you can calculate these numbers. And with these numbers, you can do your personal evaluation to see what you are able to do, so what you are able to offer to your patients, but also to follow your residents and new fellows to see if they improve in terms of techniques. Just to give you an example, it's a personal example. This is a stone 20 by 7.7, 15 and 7.3. So if you approximate the volume, again, you obtain something like 1,140. So it's more or less an equivalent of a stone of 13 millimeter. In my personal experience, knowing this number in terms of volume, knowing the density of the stone, so supposed to be relatively hard, 1,100, in my personal experience, I need 16 joules per cubic millimeter. If I'm using these parameters, 0.6, 15 hertz, so it means that I'm producing 540 joules per minute. I can calculate pre-op the total energy I will need and the timing I will do. So I can already tell my patient we will need more or less 34 minutes to complete the fragmentation, including the rest of the surgery. So if you know these numbers, your personal number, then you can fix the session in terms of number of sessions, if it will be feasible or not. This is 2 publications, the one that we did in the real life, and the second one from my good friend Khurshid Ghani. Interesting to see that in terms of stone-free rate, we do something very similar, but we are absolutely not using the same technique. Khurshid is much more in favor of high-power, high-frequency system with the Moses technology, but if you look at the total energy he's using compared to what I'm doing, he's using 2 times more energy than me to achieve more or less the same results. I'm not telling that it's bad or not, just telling you that we need to evaluate actually what we do. And if we are not calculating the volume, it's super difficult to compare what we are doing today. Again, I fully agree, stone composition is the second main factor to consider when we decide to treat patients. Thank you for your attention.